welcome you all. So today in the rapid fire round, we have Professor Dhruv Chaudhary with us, and Professor Saab, he is a Dean Academics at University of Health Science Rohtak, and he is also Professor and Head of the Department in the Pulmonary and Critical Care Department. So Professor Dhruv Chaudhary will tell us today about the HFNC. So sir, how these latest advancement in the technology in HFNC will help the patients who have acute respiratory failure?
Thank you, Deepak. You see, acute respiratory failure is a very heterogeneous etiology, has a heterogeneous etiology. In this, when you talk in terms of acute respiratory failure, you have both hypoxemic respiratory failure and hypercapnic respiratory failure. And within the hypoxemic respiratory failure, it can be because of cardiogenic pulmonary edema, it can be because of pneumonia, it can be because of ARDS. So what the data shows us today is that when we talk in terms of high frequency nasal cannulas or high frequency nasal oxygenation, it is a type of mode of delivery of oxygenation. And when we say acute respiratory failure, it means there is a failure to exchange the gas, that is oxygen, or there is a failure of ventilation. Then you see carbon dioxide going on, which is a reflection of alveolar ventilation. So when we use high flow nasal cannulas or high flow nasal oxygenation, we provide a humid air, humid oxygen to be precise, along with air. Then we also ensure that high flows are given, because during acute respiratory failure, people require flows are more than 30 liters. On an average, sometimes may be requiring of breathing at 40 to 50 also, especially when there is a drive is very high. Along with it, also it is important in terms of oxygen, because there is a fast flow. It tends to prevent the dilution of oxygen, which actually can decline or decrease if you don't take care of that, the FiO2 delivered to the patients. And along with it also take care of the dead space and can provide positive PEEP. Therefore, if you see the mechanism of action of high flow nasal oxygenation, it takes care of most of the things that are required. And besides this, there is the ease of administration, ease of giving it, and person feels comfortable. Having said that, the data which has emerged over a period of time, it has found a place especially in patients who have got acute hypoxemic respiratory failure, where it is now a class 1 indication. The only question and confusion starts when to use HFNC and when to use CPAP or NIV. For that, comprehensive assessment of patient is the key. You need to look at the respiratory rate, you need to look at the respiratory depth, along with it whether accessory muscles of respiration are working or not. In that, you look at intercostal indrawing, you look at sternocleidomastoid, Allen nasal flaring. If you have an Allen nasal flaring, take it for granted that your flow requirements are more than 30 liters. And that's what when we start coming up. And at this place of point of time, even venturi masks, they fail to take care of the ventilatory need and requirement of the patient. So that is the place where we use it. But nevertheless, when you find increased workup breathing clinically, and when it is supplemented by the blood gases in terms of low carbon dioxide, that is the time when the doubt comes up. We usually nowadays start with HFNC. Along with HFNC, when we find there is a consistent elevation of rate and marked indrawing of respiratory muscles and nasal flaring, at that point we consider either CPAP or NIV. But again, the problem with the CPAP and NIV is the mask which you are using it up. And the only place where the data in the acute lung injury, the FLORI trials and other things are very clearly shown that HFNC scores over NIV if you are using nasal mask or you are using full face mask. But if you are using helmet mask, now the data has emerged that probably it is better than HFNC. Therefore, from the ease and convenience perspective, usually patients with acute respiratory failure, especially hypoxemic, we start with the HFNC. If we find clinically supported by the lab that there is a significant respiratory distress, we can use CPAP or NIV with helmet. That's how we proceed. And in patients who have got acute lung injury, and if it is mild to moderate, that means it is somewhere between 300 to 150, you may give a trial of it, and then you see whether oxygenation is adequate or not. If your oxygenation is adequate, which we tend to look at from the ROX index, which is nothing else but saturation oblique respiratory rate, that's how you see it, plus the FiO2 which is being delivered. That's the ratio we take it up. So that's how we are looking. We have also found out in our studies that higher the numbers, 4.87 is the discriminative value when they look at SpO2 FiO2 ratio divided by respiratory rate. I can take it up like a Tobin index in ventilation, that as your ventilation settles, respiratory rate falls and your oxygenation improves and requirement goes down. So that simple basic principles you see it, and that is one part. Now its role is now evolving in hypercapnic failure per se because of your COPD. The data again shows, our studies also show it, again the data which has been published, it also shows that it is non-inferior. But nevertheless, still NIV continues to be a preferred choice in patients of acute exacerbation of COPD with type 2 respiratory failure, because that supports the muscle much more. Therefore, it can lead to unloading of respiratory muscles, and hence where patient feels more comfortable. But whatever the data still has emerged, it is non-inferior, but few of these patients may be shifted over to NIV. But where indication is very clear cut in acute respiratory failure and also acute hypoxemic failure, if FiO2 or PO2 FiO2 ratio is less than 100, 150, it is better straight away looking out general condition to go for intubation straight away.
What are the possible complications, sir, when we are using the HFNC, and how to deal there?
You see, HFNC, one of the most important thing which we commonly tend to see with them is nasal bleeds, which can happen because they can occur at dryness. Therefore, humidification is very important, and we usually try to give it at the same as the room temperature. So the body temperature, 37 is one. Don't do more, don't do less. So keep it around 35 to 37. That is one part. Secondly, you should use lubrication to avoid it. Secondly, in this case, unnecessary continuation of it when it is not required has led to increased mortality, morbidity. Finally, hyperoxic injuries are also known and being defined. These are the few side effects, but ease is much more. And another thing what we realize is because it is an oxygen guzzler, because then the cost of the treatment may go up vis-a-vis NIV.
Thank you so much, sir. So I think sir already explained how we have to use the HFNC and which subset of patient it has to be used and how to monitor it. So thank you so much, sir.
Thank you, pleasure.